In a recently published review in the Journal of the American Heart Association, we revisited the hallmark EKG features of ventricular tachycardia. They are shown in this figure here. I've also placed a link to this article in the comments below, or you can simply search for it to have access to this figure. In general, wide complex tachycardia differentiation methods comprise one or more ECG criteria that embody distinctive electrophysiologic properties of ventricular tachycardia and supraventricular wide complex tachycardias. Now, the available methods that utilize these EKG interpretation criteria, they examine a few things, and they're listed here. They look at the relationship of the atrial and ventricular depolarization wave. In other words, the presence or absence of AV dissociation. They look at morphological configurations of the QRS complexes and specific leads. They look at the QRS duration of the wide complex tachycardia. They look for chest lead concordance. They look for the mean ventricular axis in that frontal plane, differences in the ventricular activation velocity, as well as variations between the wide complex tachycardia and the baseline EKG. While all have proven their value in distinguishing both ventricular tachycardia and a supraventricular wide complex arrhythmia, no single criterion or a collection of criteria comprises diagnostic certainty. Okay, so none of them promise any diagnostic certainty if you're able to find them. Now, in this lecture, we're going to focus on one of these, okay? And we're going to focus on the relationship of atrial and ventricular depolarization, specifically the presence or absence of AV dissociation, which is this one here. Again, if you want to find this review and get a head start, you can look for this article, okay? I've put the reference here. Again, and this is published just recently in the Journal of the American Heart Association, and you can find that there. All right, so let's get started. Wellens and colleagues highlighted the importance of atrioventricular or AV dissociation in 1978, which later matured into one of the most trusted EKG criteria to secure a ventricular tachycardia diagnosis. Now, as a general rule, ventricular tachycardia may be confirmed once AV dissociation is present, especially when the ventricular rate exceeds the atrial rate. Not surprisingly, several wide complex tachycardia differentiation methods actually include AV dissociation as a key VT diagnostic criterion. However, although AV dissociation may be quite valuable in establishing a VT diagnosis, its absence does not rule out VT, since it's not always found or seen on the EKG, even amongst those with known VT. Now, by definition, AV dissociation is present when a self-governing ventricular rhythm autonomously subsists the atrial rhythm. Okay, so what does that mean? You have something here in the ventricles. Imagine that this is your ventricular focus that is pretty much subsisting or self-governing, taking over electrical activity of the heart. Now, classically, AV dissociation is characterized by a series of QRS complexes uncoupled from dissociated P waves. When interpreting a 12-lead EKG displaying VT, AV dissociation may be recognized as interspersed P waves that are nestled between or hidden amidst overlapping QRS complexes and T waves. If you look at this figure here, I've highlighted them. So these are the P waves that we're actually seeing in this lead V2. So notice here are two P waves nestled in between our QRS complexes, which are these ones here. Okay, so notice they're quite difficult to see, even hard to see in lead V1, but they are there in this case. And so, as you can imagine, these are sometimes even the best EKG interpreters have difficulty trying to identify these. Now, less commonly, AV dissociation manifests as a capture or fusion beats, each of which depict varying degrees to which a supraventricular impulse contributes to ventricular depolarization. In the case of a capture beat, an ideally timed supraventricular impulse seizes ventricular depolarization entirely and produces a single QRS complex resembling the patient's baseline rhythm. So what does that mean? Now imagine you have, here's your sinus node, okay, we can say this is our SA node or sinus node. We have conduction that's coming through the atria, through the internodal pathways, even maybe to the left side, to the left atrium, through that Bachmann or interatrial conduction fibers, coming to the AV node, going through the His bundle, and then passing through. Now imagine that you have this ventricular focus somewhere here that's still going, and it's producing impulses, and you have ventricular tachycardia in this patient, but you also have a sinus rhythm or an atrial rhythm going on. At some point, you may have a sinus beat that just goes at the exact right time and captures the ventricles. And as a result, if it's able to capture the ventricles, and it may appear as what we call a normal QRS complex, resembling the patient's baseline. Okay, so here's a capture beat, ideally timed supraventricular impulse, so coming from above the ventricle, seizing ventricular depolarization in the setting of this ventricular ectopic focus, and resembling a normal or baseline QRS complex on the EKG. That's what we call a capture beat. Now in the case of a fusion beat, this is where ventricular depolarization wavefronts emanating from a supraventricular and ventricular focus collide and create a hybrid QRS complex that shares the morphology of the ventricular depolarization characteristic of the VT and the baseline rhythm. Okay, so imagine, and this is a little different, okay, so what's happening here is, imagine you have a atrial or supraventricular rhythm. Let's say it's coming from the sinus node. Okay, so coming from this way and also coming from this ventricular focus. The ventricular focus is going to depolarize the ventricles, okay, such that all of these. But imagine that you also have this atrial or supraventricular focus that's coming down, and that they eventually make their way down, that both wavefronts collide, okay, during the phase of ventricular depolarization. As a result, you get this hybrid QRS morphology. So a fusion beat is when you have the ventricular depolarization wavefront emanating from both the supraventricular source, the one up here, and the ventricular sources. They collide, okay, the wavefronts collide, and they give you this hybrid QRS that looks like maybe the ventricular tachycardia QRS and then a normal QRS, okay? So this is what we call a fusion beat. So you get the hybrid, it looks like both. That's what we mean by the hybrid. Now, identification of AV dissociation can be quite challenging, as we've mentioned. In general, AV dissociation may be recognized in roughly 1/5 of ventricular tachycardias recorded on a 12-lead EKG. For many cases, VT will coexist with an atrial arrhythmia, such as atrial fibrillation, that lacks organized atrial depolarization, such as P waves. In other cases, AV dissociation simply cannot be recognized because of overlying QRS complexes in T waves obscuring the dissociated P waves. Furthermore, it is essential to recognize that up to approximately half of ventricular tachycardias will demonstrate retrograde ventricular atrial conduction, wherein the ventricular impulses conduct retrogradely through the His-Purkinje system to depolarize the atria. And in such cases, ventricular tachycardias will not exhibit AV dissociation. Instead, they may demonstrate a regular one-to-one ventricular atrial conduction or an erratic ventricular atrial conduction with a variable block relationship. Okay, and so just so you're aware, the VA conduction, when we talk about that retrograde conduction, it's coming from that ventricular source and conducting retrogradely to depolarize the atria, okay, but coming from there. So that's what we mean, ventricular or VA, meaning going from the ventricles to the atria. That's a retrograde conduction. All right, so let's review what we discussed here before we end. So AV dissociation, one of the most trusted criterion for VT, okay, so this is a key one, especially if the ventricular rate is greater than that atrial rate. Now this results from a self-governing ventricular rhythm subsisting or overriding the atrial rhythm, okay, so pretty much taking over pacemaking function of the heart. Now its absence does not rule it out, and there's a few reasons why. Okay, now it's not often apparent, so it's hard to notice, and it's often only recognized in about 20% of ventricular tachycardias. So we're saying of not only wide complex tachycardias, of the VTs that are actually ventricular tachycardias, only 20% of them tend to have recognizable AV dissociation. Now, this may also coexist with an atrial arrhythmia, such as atrial fibrillation, which we know in atrial fibrillation has no or indiscernible P waves, so we can't really make out any of the P waves because there's no good atrial depolarization waves present on the EKG, and as a result, when you're looking for maybe the P waves, they will not even be there. There could also be retrograde ventriculo-atrial conduction, as we mentioned. Now, the EKG features you want to look for are the QRS uncoupled from the dissociated P waves, as we saw here in this EKG. Okay. Now, you can also look for capture and fusion beats. Remember that capture beats is when you have an ideally timed supraventricular impulse that seizes ventricular depolarization, and you get a QRS that looks like the patient's baseline EKG. Okay, and the fusion beat is when you have a ventricular depolarization wavefront, so from the ventricles, and one impulse from the supraventricular source. They come down and eventually they collide. Okay, and as a result, you get this hybrid QRS morphology that you see on the EKG. Well, that's the end of this lecture. We discussed the importance of and how to recognize AV dissociation in differentiating wide complex tachycardias. I hope you learned something. Now, just to keep you in mind of our course material that we have available, so again, if you go to our website, www.ekg.md, okay, so this is our website, and what you'll notice is that if you go to the EKG course here, okay, you'll find stuff that's separate. So notice that we have a number of topics, practice material, lectures, a way for you to contribute, and this is the course here over here. So you'll notice we have over 300 videos or so, and that's more on YouTube. There's another 100, more than 100, about 200 videos that are available with the course. So those are separate videos, and this course is really designed to take you from a beginner to advanced interpreter. Okay, so completely separate from what you're getting online for free. Okay, these are course material that comes with it. So notice that you have a book. Okay, and then you also have the pocket guide available, so you can choose which format. They are the same thing, both these book and the pocket guide, different formats. I really like this small one because you can keep it in your white coat if you're in the clinic or in your pocket, and it's really available on the go. Now, with the book, you also get videos. So notice these are the videos, okay? And these are a video for every single page in that book. So it's over 30 hours of video. Now, there's a number of practice material that I continue to upload there. Okay, we'll have practice questions coming soon. So all of that's available. Again, this is separate from all the free material that you get already. Okay, so this is more high yield stuff. This is what we used to teach our technicians here and our students here at Mayo Clinic. And it's used now among many institutions. So check that out. Now, what it also includes are calipers. So yes, you get calipers with this course. Okay, I don't know anyone else that offers that, but you do get calipers. I think they're very helpful, and they can, if you know how to use them correctly, can help to identify different arrhythmias that are going on. Okay, and then you also get our pocket EKG reference. Okay, this was something we've put together as we were developing course for the fellows, and this is really nice. It has every code, as you saw earlier, laid out there. Very small pocket guide available. I had help with my colleague, Dr. Peter Noseworthy, who's the head of the EKG lab here at Mayo Clinic, in editing it. So this is something that we use and we found very helpful. So go to the EKG course. You'll see examples of lectures, okay, why we developed this, okay. A lot of it came about from myself struggling with learning EKGs, having a father that was an interventional cardiologist and, still struggling. So my struggle is a struggle that I don't want you to have in learning them, okay. You can read all those introductory books, but honestly, they are not enough, okay, and you find yourself using other resources, which is part of the learning process. I wanted to expedite that process for you and make it less inefficient in pretty much what I struggled with going and learning through EKG. So again, from beginner to advanced level with this course, you get the book, the calipers, the coding reference, video access, okay, and now we're offering 25% off. 25% off. Put that code in on checkout, and you'll have yourself 25% off that will even, it's pretty much covers the cost of what we use to print the material. So we don't really make much off it. It's more to help our learners grow and really be able to contribute to patient care. That's why we do this, and we love doing it. So thank you so much for your support. If you have any questions, just leave them below, and we're happy to answer them. All right, have a great day.